Tonight's presentation is called Neurocognitive Dysfunction After Aortic Surgery, Protecting the Brain While in the OR. But before we get into it, just a review, we do offer Category 1 ABCP credits for these. And there's only a couple of things you have to do, and I'm sure this is be reminded to people. Please stay logged in for 45 minutes or more and complete the post survey that I'll show you in just a second. The certificate will be emailed. They usually come out within about a week's time. And then the presentation will be recorded, and it's also going to be shown on YouTube. The survey is pretty simple. Right here is what the 3 questions are. And again, if you have any comments and subject matter or topics that you would like us to address, please send me or Craig. You'll see our emails at the very end of this presentation, and we will make sure that we get that subject matter. And if you have speakers you'd like to hear, we will go ahead and invite them accordingly. The discussion section, Dr. Firstenberg will be presenting for between 25 and 30 minutes. And then we have a 20-minute presentation, discussion, Q&A. And as I mentioned, Craig will go ahead and run most of this. So I'd like to introduce our speaker tonight. He's well known to all of us, primarily over the last several years due to his phenomenal work with ECMO. But Dr. Firstenberg is a board-certified thoracic surgeon who specializes in adult cardiac surgery. He serves as the Director of Research and Special Products for the William Novick Global Cardiac Alliance, and he holds multiple appointments in College of Medicines across the United States. He's a graduate of Case Western University Medical School, and he received his general surgery training at the University Hospitals in Cleveland and completed fellowships at both Ohio State University, or should I say the Ohio State University, as well as the Cleveland Clinic. He's an active member of both the STS, the AATS, the American College of Cardiology, the American College of Academic and International Medicine. And he was a founding fellow of that, as well as the president in 2021 and 22. He's written over 200 peer-reviewed index manuscripts, book chapters, and abstracts. And as I mentioned, he's edited several textbooks. The one most recently that I'm aware of course, is on ECMO. But he's also done that on medical leadership, patient safety, and endocarditis. So with that, I'd like to welcome Dr. Firstenberg and look forward to his presentation. Dr. Firstenberg.
Thank you, Al. That is quite an introduction and much appreciated. Hopefully my share screen is coming through for everybody. And can you, is it coming through? Okay.
Yep, I can see it.
With no further to do, because this is an important topic, and I appreciate you getting the Ohio State University right, as well as the Cleveland Clinic. And so I will also apologize a little bit that my voice is a little raspy. I think whatever you've come down with, you've probably spread it to the rest of us, potentially virtually. So I will apologize in advance. And just to jump in real quick, I do not have any relevant conflicts of interest or disclosures. And you could, although somewhat argue that some of the things that we're going to be talking about today may be a little bit off label in the approaches to how we use our technology. First and foremost, I think we all can recognize that neurologic complications after cardiac surgery, unfortunately, are not uncommon. The etiology is complex and multifactorial, and without a doubt varies based upon the type of surgery that is performed. There are a variety of interventions that can be done at the time of the operation by all members of the team to reduce the risk. However, that's probably offset by the increased complexity of the procedures that we're performing, as well as the comorbidities of the patients that are undergoing surgery. And in catching up with that, there is sort of evolving literature on some of the role of potential diagnostic assessments and the opportunities there for timely intervention to reduce the risk and do something about it if there is an event that happens. So to begin with, neurocognitive dysfunction can occur in up to 40 to 50% of patients after cardiac surgery. Now, while that may seem a lot, remember the definition of that is quite broad and is often attributed to what we would all call as pump head. And some of it is more complex and not always inevitable. Many patients are even asymptomatic but will have new lesions on their brain MRIs when you do a deep dive and study it. There are a variety of incidents of definitions and detection methods, depending on how hard you look for some of these things. And as most of you know, we're all sort of in denial of problems. Don't want to look too hard, but it is a reality. And we do have to recognize that it's not uncommon for some of our patients to have some degree of brain issues, whether it's word association, problems with short or long-term memory, verbal scores, eye movements, motor function, after surgery, that can range from even just a little bit of anxiety or delirium all the way up to full-blown strokes or coma. And more often than not, the patients or their families complain that they're just not themselves. And sometimes it's very difficult to separate neurocognitive dysfunction after cardiac surgery from the normal aging process. And to understand it, we do have to recognize that there's a full spectrum of mechanisms. Ranging from microemboli, including air, no matter how much we try to avoid it, brain ischemia from localized or global low flow states. There's a variety of inflammatory or cytokine activation and responses that occur just from the act of cardiopulmonary bypass. The potential role of medical problems, not just the microvascular disease, for example, that comes with diabetes, but sometimes there's evidence that insulin resistance alone can cause some problems in this patient population when subjected to the physiologic changes that go on during cardiopulmonary bypass, as well as some concern that the non-pulsatile flow and pressure changes can lead to disruption of the blood-brain barrier and contribute to cerebral edema. There are a variety of therapies and interventions that have been shown, at least in the context of cardiopulmonary bypass, such as the use of heparin-coated circuits, maintaining adequate flow on bypass, strict glucose management, slow rewarming when we do cool patients, trying to avoid multiple manipulations of the ascending aorta. Some evidence that monitoring cerebral oximetry and some of the more advanced neuromonitoring techniques can help avoid and identify early hypoxia to the brain. And then also some of the mechanisms related to acute kidney injury in themselves are also linked to somewhat synergistic, unfortunate brain injury. There are some interventions that have not been shown to be of benefit or are unclear at this time. There's quite a bit of controversy regarding the role of different types of anesthetic agents, as well as we all know, the controversies that surround on-pump versus off-pump bypass techniques and the use of cell saver. There is some question as to whether the role of steroids, transfusion, or medical interventions or hyperoxygenation may play a role, but for the most part, those have not been proven, even in a variety of studies at this point. I think we really need to understand that most of the data that is out there when broadly applied to cardiopulmonary bypass either applies to normothermic and or mild hypothermia. But we need to understand that particularly in the setting of aortic and arch surgery that is becoming more common, the real stories are much more complex. When we start looking at patient risk factors, I think it's pretty obvious to most of us that older age, baseline neurocognitive dysfunction, either as manifested by a history of mental health disorders like depression or stroke, are sometimes viewed as risk factors. Education alone, interestingly, can be, and the mechanism of that is somewhat unclear. Clearly, the burden of atherosclerotic disease, both large and small vessel, anemia, concomitant carotid, or as I mentioned, diabetes. And what I really want to focus in on today is the type of surgery. While any type of intracardiac procedure, such as on valves, is associated with an increased risk, most of our conversation and discussion today will involve the ascending aorta and the aortic arch. If you go back to William Osler years ago, I really like his quote, and I've used this in a variety of circumstances, and that is, there is no disease more conducive to clinical humility than aneurysms of the aorta. I think it's pretty well established even 100 years later that that fact is still true, and it still challenges us on a day-to-day basis when we have to manage these types of problems, even though our therapies are getting better. I don't want to spend too much time on this, but at least framework our conversation on looking at aortic diseases in terms of, at least in my mind, two different distinct types of pathology, either aneurysms or dissections. We need to recognize that there are different indications for operation in both. Aneurysms can become dissections, and likewise, dissections can become aneurysms, and there is clearly overlap between the two. But in the real world, it's not always easy. Furthermore, there are a variety of classification systems, and much of them are based upon what part of the aorta is either aneurysmal or potentially torn. And the way that we sort of think about it more in terms of surgery and surgical emergency, and that is if it involves the ascending aorta, and especially if there's a tear, there's a much greater sense of urgency or need for intervention. Most of the aneurysms involve either the ascending or descending, but we also have to recognize that the aortic arch is involved as much as 10% of the time, as well as the thoraco-abdominal aneurysm. So these can be quite challenging to manage. When you start looking at independent risk factors for mortality, one of the things that kind of pans out are that they are often the same risk factors for any type of neurocognitive dysfunction. Emergent operation, heart failure, age, the length of the operation, whether there's a concomitant dissection or need for CABG, obviously re-ops, and again, the need for an arch intervention also clearly plays a role in this. And when you start looking at then the late survival, even though most patients do pretty well at 1 year, it really starts to fall off between 5, 10, and as high as 15 years. And one of the reasons for that is obviously bleeding, uncontrolled bleeding, or underlying cardiac cause. But often the decision to either withdraw support or why a patient ultimately dies is fundamentally based upon some degree of neurocognitive dysfunction, because a lot of times we just feel that these patients are irreversibly neurologically damaged, and moving forward is probably a sign of futility. So moving then to a little bit on aortic dissections, they represent one of the true emergencies that we need to deal with in our world, and often illustrate a little bit of why we fix aneurysms. This just illustrates a few very well-known people who ended up dying of complications of aortic dissection. And while I find it interesting that we deal with this all the time, it is still something that is not very high on a differential or radar when people coming in with chest discomfort or symptoms that would make you want to think of an aorta. More often than not, these people get worked up for acute coronary syndromes or pulmonary embolisms. Dissections likewise also have a similar scoring system or classification system, again, really based on whether we take the patient immediately to the operating room or whether we manage them medically, and that is based upon whether there's involvement of the ascending aorta, and particularly if it involves the arch. And when you start looking at it this way, it then starts then impacting the actual technical aspects of how we fix the operation. Specifically looking at dissections, again, when they start involving just the ascending aorta, the mortality, although it could be up to 30% depending on the comorbidities, it's really much more substantial when we start dealing with the aortic arch as a manifestation of all the complications that can be associated with it, as well as the significant technical challenges that come with the operation itself. And again, recognizing that neurologic dysfunction after surgery or neurologic complications are often a substantial cause of both early as well as late morbidity and mortality. So the real question is then how do we avoid some of these problems? And we need to recognize that despite different presentation pathologies, the issue of neurologic dysfunction is very complex. And when you tie that in with the pathology that we're faced with, we also need to recognize that not every aspect of what is broken in the aorta needs to be fixed at that time. And while we are using similar techniques, there is a constant evolution with a learning curve, and we need to understand the natural history of the pathology to try to really achieve our primary goal, and that is to have an alive patient at the end of the day. doing sometimes an extensive operation that may be, as we say, too much surgery for a patient, particularly given their comorbidities of their age, probably ultimately doesn't do them any benefit if they don't survive, or worse, they end up neurologically devastated. So one of the more common applications or techniques for simple aneurysms is, as we call, a simple supracoronary tube graft. Typically, this is done when the arch is relatively normal. We don't need to reimplant coronaries. The aortic valve is okay. And the arch itself is relatively free of disease. Typically, we can cannulate the aorta directly and do an interposition tube graft. And that tries to avoid some of the potential complications that we see from using some of the innovative aspects of cardiopulmonary bypass to try to get to the arch. We need to recognize that it's not always this simple. If there is arch involvement, we have to be a little bit more creative. Sometimes patients, as a sign of their underlying cerebral vascular disease, will have an incomplete circle of Willis, which may predispose them to malperfusion syndromes of the brain. And that's why we need to always have a strategy for using alternative perfusion options, as well as a plan for protecting the brain during surgery. Because when we start getting a little bit more complicated, we can then start thinking about things such as antegrade cerebral perfusion, which I'll touch on a little bit more in a few minutes. The two major approaches to that are either with axillary cannulation, which allows for a nice, simple, clear field. There is some concern that it may be a little bit more time consuming because it does involve cutting down on the axillary artery, identifying the artery, and either cannulating it directly or sewing on a tube graft, or what we call direct cannulation or selective antegrade cerebral perfusion, where we perfuse the brain directly through the head vessels from within inside the arch. Again, raising the concern of an incomplete arch may predispose to problems if you are not perfusing both sides of the brain. There is still some concern that direct cannulation of the head and neck vessels may dislodge some debris, as well as potentially predispose you to vascular injury and increase the technical complexity of the operation. So as you can see, there's advantages and disadvantages to both. However, when you do have to operate on the aortic arch itself, one of the more common approaches, particularly in the setting of an aneurysm or dissection, is reimplanting the arch head and neck vessels as an island, where you take typically all three of them, as you see in the figure A here, and you do an enlarged anastomosis to a graft that is going both proximally and distally, and sew that in. While it looks pretty simple here on the pictures, trust me, it is a lot more complicated to do it in the operating room, as the exposure can be quite challenging, particularly with patients that are quite large or that have a lot of heavily calcified disease and getting good mobilization. When you extend that then to an elephant trunk procedure, which involves reimplantation of the head and neck vessels, again, you're starting to look at then either deploying a stent graft or extending in the graft into the descending aorta so that you can fix the descending at a later time. Again, the emphasis is trying to simplify a very complex operation, very complex set of pathology in a way that you are looking at a staged approach to the problem, not fixing everything at the same time, and making sure that you provide adequate cerebral flow and minimizing either embolic, ischemic, or air debris from impacting your brain, because these procedures are risky enough as they are. This then evolves into sometimes alternative replacement techniques where there's minimal manipulation or allow for somewhat staged procedures where we can interrupt the perfusion to the brain or the body at different times, so that we're not subjecting the entire body to intermittent ischemia, but rather different parts for shorter periods of time. So for examples that I illustrate here, you're sewing, for example, a graft onto the aorta first and then dealing with the head and neck vessels separately, or vice versa, depending on the conduct of the operation, or sometimes independently sewing separate graft in an end-to-end anastomosis to the different head and neck vessels. These are actually very technically challenging, particularly when you have small friable vessels or heavily diseased vessels, but it does open the opportunity then for evolving techniques for extra anatomical bypass and reconstruction that are particularly helpful in patients that have had previous surgery. So for example, this was a patient that we operated on a couple of years ago. And as you can see from the cartoon, it is quite simple. This is a patient that had a previous ascending aneurysm repair, who at 75 years old came back with extensive arch and descending aneurysms that had been getting larger, clearly having indications for urgent operation. And we were then able to perform this as a staged operation, as you can clearly see in the picture, where using off-pump techniques, avoiding cardiopulmonary bypass and avoiding direct manipulation of the vessels, doing two separate end-to-side anastomoses, one proximal to the ascending aorta by the graft, and then going up to each of the head and neck vessels. And then once that was done, bringing him back at a later date for a left subclavian to left common carotid bypass, and then ultimately at a later time, stenting over the entire ascending aorta, arch and descending, while allowing for extra anatomical bypass perfusion to the brain the whole time. So again, demonstrating that when you start thinking about these things in a creative manner, sometimes extra anatomical techniques are the best. So really, to identify the problem, we have to understand the key principles. And that is, we need to maintain adequate brain perfusion during management of the arch and head vessels, limiting the embolic risk of any type of debris or air, while also allowing for a clean and bloodless field to work. It doesn't do you a lot of good when you're trying to do baseline, a very difficult technical anastomosis, if you've got a field full of blood. And while you need to recognize that these goals are not always achievable, you need to balance the risks and benefits of different techniques to try to make it as easy as possible. And that's why the evolution of deep hypothermic circulatory arrest has come over time and is becoming much more common even for straightforward aortic surgery. I remember when I was doing my training at the Cleveland Clinic, Bruce Lytle used to use some degree of circulatory arrest on all of his aneurysm cases. And I think that just reflected the fact that he wanted to eliminate as much pathologic aortic tissue as possible, and also recognizing the fact that he and his team could do this routinely with minimal risk and significant benefit. We need to understand what the definitions are. So most of the time, particularly for those of the perfusionists that are on this call that have been working with me, they know that I don't like to cool too much. So mild hypothermia, typically 30 to 40 degrees, 34 Celsius, excuse me. Moderate comes down to about 25 to 30, and then deep hypothermia as low as 15. Circulatory arrest implies no flow to any of the blood vessels, essentially stopping the pump. And then when you throw that in with deep hypothermic circulatory arrest, during periods of deep hypothermia, we avoid all blood flow to the body. So typically we need to recognize that usually it's planned. And I say usually because sometimes it's not, and you must be prepared for some degree of circulatory arrest in almost any case. I mean, for example, I was doing a routine CABG a couple of years ago, and for reasons that are still a little unclear, we ended up dissecting the ascending aorta, which then required a little bit of a change in the operative strategy. You start cooling relatively quickly and measuring esophageal temperatures, rectal, nasopharyngeal, and tympanic to make sure that we're getting the same results. And once you get down to a fixed temperature, the arterial pump is stopped and clamped, and you drain the patient out as much as you can. And this then allows for then manipulation of the field, such as inside the arch, in a way that is typically bloodless. And you need to recognize that you need to move pretty quickly. Once you're done with your period of circulatory arrest, you start your perfusion up again, and you do careful de-airing, try to flush out as much degree as possible, and reapply the cross clamp as needed, and start your perfusion. Sounds barbaric, and the real question is, why do we want to end up doing it? As I mentioned, it does allow for a bloodless operating field and improved exposure to help with the technical aspects of it. There is some evidence that it may actually reduce some of the harmful effects of cardiopulmonary bypass during some of these delicate periods, as well as reducing manipulation of the aorta and arch that have been associated with increased risk of embolism. It can get cannulas out of the field so you have more room to work, as well as leading to less anatomical distortion. And there is some evidence that it does reduce and less fluid accumulation, as well as cytokine activation. The practical aspects of that are still somewhat unclear. I think most of the people listening have seen some variation of this slide over time, and that is really the quote, safe duration of circulatory arrest is a function of not only the temperature, but also the time. I think it's obvious the colder you are, the longer that period is, but as you can see, it does drop off pretty quickly. It is extremely variable and patient specific. It is impacted by a variety of comorbidities and how you are measuring the brain temperature, particularly since brain temperature can fluctuate significantly. There is some concern that the rate of rewarming impacts it. The data on neonates doesn't necessarily apply to adults, but recognizing one, that there is no ideal safe duration, and it is always a balance of risk versus benefit. We do recognize that colder is always better, but one of the things that drives perfusionists crazy when I'm working with them is that warmer can be okay too. While it's very difficult to study this in adults, even brief periods of normal circulatory arrest, even just to take a look inside the arch or to fix a few stitches is very well tolerated with minimal risk of short or long-term consequences. We need to also recognize that there are a variety of ischemic responses that are somewhat both pro and con. There are things that exaggerate the damage to the brain, as well as things that get activated during these periods of ischemia. But the key point in all this, without spending too much time, because I'm not sure anybody understands it, is that these are very complex mechanisms, and sometimes the end result is not always known for days or weeks, meaning even for patients that have some degree of early neurocognitive dysfunction, they can either evolve and get worse, particularly if there's secondary insults, or given enough time, despite the worst of initial outcomes, they can actually resolve their brain injury and be perfectly normal, at least according to their families down the road. So then that raises the question of what are some of the other opportunities for involvement, particularly in the perioperative management. Communication amongst the entire team, both with anesthesia, surgeons, perfusion, nursing, everybody is critical, because hypothermic circulatory arrest really is something that really gets the clock ticking much more than anything else. And as I emphasized, just because there's limited value of some of these interventions with conventional bypass, that doesn't mean it's not helpful when using deep hypothermic circulatory arrest. So the management of anesthesia, the duration, how fast and the depth of cooling and rewarming, pH management, which I'll talk about in a second, hematocrit, hemoconcentration, steroids, perfusion techniques are all very important for how we try to reduce neurocognitive dysfunction. As I mentioned, pH management is particularly important. I think it's important to go back to the core concept that when blood is cooled during bypass, the pH moves it more to alkaline. A pH stat strategy involves adding carbon dioxide to compensate for this shift. And with it, with an alpha stat strategy, the hypothermic blood is more alkalemic and hypocapnic, whereas with a pH stat, blood at 37 degrees is more acidemic and hypercapnic. The reason for that is that with an alpha stat strategy, there is evidence that it preserves the autoregulation, optimizes the enzymatic activity of the brain, and less metabolic suppression. With a pH stat, there is evidence that it improves cerebral blood flow, oxygenation, and cooling efficiency. But there is some concern of a greater risk of microembolism and free radical damage. I think the key point in all this is that the pH management is probably even more controversial than religious beliefs when you look out there, and everyone has their own opinions as to which they think is the best, but recognizing, identifying one and sticking with it. There's a variety of studies out there that have suggested that optimization of hematocrit during circulatory arrest is beneficial. This was just one brief study that just looked at a pig model with 3 different groups getting different degrees of hemodilution with either crystalloid or blood prime. And after about 60 minutes of circulatory arrest at 15 degrees, they evaluated the function of the brain immediately, as well as for the first several days, and then doing neurohistologic score assessment. And what they found was that those patients, or excuse me, those pigs that had the most significant hemodilution had the worst both short and 4-day neurocognitive dysfunction, meaning that some degree of either hemoconcentration or optimization of hematocrit, such as priming with whole blood, was associated with the optimal preservation of high energy phosphates and better early neurologic dysfunction, and that most of the group overall got better, but recognizing that there was some brain injury. This also looks at the role of steroids. Again, this was an animal model that has led to a variety of clinical models that demonstrated the use of methylprednisolone during deep hypocirculatory arrest. And what they looked at was the different areas of the brain in terms of how they recovered after circulatory arrest, with a much more profound and significant improvement in brain function in the cerebellum, the brainstem, and the basal ganglion when compared to controls. This sort of led to the conclusion and why the widespread adoption that the use of steroids is, one, relatively safe, inexpensive, with few downsides, and offers what is believed to be some degree of diffuse brain protection during these periods, which is why most people will give it. The science of this is extremely complicated, and I just want to touch on this because it's really been only in the past 10 to 20 years that we're starting to understand some of the complex autoregulatory function of the brain during extracorporeal perfusion. And that some of these early animal studies, for example, have been trying to look at, for example, near-infrared spectroscopy, and have found that different areas of the brain are perfused differently. And that's why we need to keep in mind that what may be one way of measuring brain function may not necessarily be adaptable to the entire brain, and that there is significant damage to the brain that not only lasts during the procedure of in question or when you're cold and at arrest, but even in the first few hours, if not several days or weeks after the initial insult. And that has led to the concept of preconditioning. And preconditioning is based upon some degree of a subthreshold insult prior to a severe insult that in theory would lead to decreased brain injury, meaning a benefit. However, there is also some balance by the concept of sensitization, which is often known as the 2-hit hypothesis, where there is some degree of a sub-threshold insult, then followed by a severe insult, which then results in an increased injury. So how do we determine which person is going to benefit from preconditioning and which one is going to be made worse? And the short answer is we really don't know. While in general, the concept of a remote ischemic preconditioning does sound good, unfortunately, when you start looking down these pathways of doing some degree of a preconditioning stimulus to try to sensitize the brain to an eventual ischemic event, we can't always predict based upon the complexity or the genetic factors of the patient or the comorbidities, which patient is going to ultimately benefit from it versus which patient is ultimately going to be harmed from it. And while there was a lot of excitement early on, including some New England Journal of Medicine articles looking at very simplistic remote ischemic preconditioning, when they looked at this with a meta-analysis of randomized trials, unfortunately, they really didn't show any significant benefit, meaning that remote ischemic preconditioning, at least in the context of overall cardiac surgery with cardiopulmonary bypass, there really wasn't any substantial benefit. Fortunately, we weren't harming people, but it did raise the question of whether the approach that we used with the anesthetic agents, such as with propofol, or the role again of acute kidney injury, may predispose certain patients to having a benefit or not. And like every other meta-analysis or randomized trial, it can concluded with the fact that we need to do more research on this. And with that, I want to then segue to some of the cannulation techniques. I think hopefully most of you are familiar, as I mentioned before, either with axillary cannulation or selective antegrade cerebral perfusion, and the advantages and disadvantages of both of these. Personally, I tend to prefer axillary. I think it's a lot simpler. It keeps things out of the field. It's easier to manage, but nevertheless, that doesn't mean that there isn't a substantial role for selective antegrade. And in fact, this was a meta-analysis that came out earlier this year looking at neuroprotective circulatory strategies for patients that are having open aortic surgery. They evaluated 15 studies, and of those, almost 6,000 patients, with the majority of them having some degree of moderate circulatory arrest and almost about 2,000 with deep hypothermic arrest. The etiology of these patients were predominantly dissections, both acute or chronic, but a third of them had degenerative aneurysms. And what they found was sort of across the board, moderate hypothermic circulatory arrest actually was better than deep hypothermic arrest, both in terms of bypass times, cross-clamp times, and over-operative times. I don't think that should come as a surprise to anybody, particularly when you spend a significant amount of time both cooling, rewarming, and then, as we say, cleaning up afterwards and dealing with the coagulopathy that sometimes develops. However, taking this to the next step, what they realized that there wasn't really a substantial change in the mortality, although there was a slight benefit for those patients with moderate hypothermic circulatory arrests with selective antegrade cerebral perfusion compared to deep hypothermic. And likewise, there was a decreased incidence of stroke, although it was very slight when using the moderate hypothermic techniques. Now, that's not necessarily to say that we should throw the baby out with the bathwater with regards to deep hypothermia, but it is something that we need to have all of these different tools and techniques in our armamentarium. When they specifically looked at a subgroup analysis involving just the arch alone, the results were a little bit more profound, and that is the moderate hypothermia with selective antegrade perfusion had a much lower ICU stay and much lower overall length of stay, illustrating that really there is some degree of balancing the simplicity of moderate hypothermia and selective perfusion with some of the physiologic and technical complexity that comes with deep hypothermia. And this was even more profound when you started then looking at the coagulopathy that had developed in the deep hypothermic patients, again, favoring the moderate, which again also has an impact on both short and long-term consequences. How long these patients are intubated, again, a longer recovery time is also associated with worse outcomes. And as a result, it did suggest that deep hypothermia, while can be employed safely, it is something that needs to be used with caution. Something that I was always intrigued by was the concept of retrograde cerebral perfusion, which basically allows for arterial inflow directly up the superior vena cava. Typically, the SVC is cannulated, almost like we do in a bicaval situation. It is isolated, and during periods of moderate hypothermia or even deep hypothermia, selective arterial perfusion is performed to essentially try to perfuse the brain. The original concepts of this came back many years ago, and this just illustrated one study that looked at 52 patients that demonstrated that using retrograde cerebral perfusion in the setting of deep hypothermic circulatory arrest resulted in a very favorable outcome profile, particularly in a complex patient population of both congenital, pediatric, and adult cases. They were able to cool down substantially with prolonged periods of circulatory arrest, as high as 88 minutes, with pretty favorable outcomes. 6 early deaths, which is not unusual when you consider these types of procedures, of which most of them were related to cardiac, and there were only 2 peri-operative strokes. All the patients recovered without any other significant neurologic deficit, demonstrating that this is a safe approach that allows for protecting the brain. And specifically looking at this in terms of how long we can do it, as you can imagine, studies on this or large studies are somewhat hard to come by. But this is actually a study that just came out recently looking at the duration of it in a very large aneurysm and dissection population that came out of Texas, a group that does a lot of this kind of work. And as you can see, the configuration of selectively cannulating the SVC at the time of bypass. A very complex and sick patient population, tending to be older, other comorbidities that we typically see, concomitant coronary disease, diabetes, some degree of cerebral vascular, renal disease, and patients that have had previous surgery, urgent and emergent procedures as well. So a very sick population at high risk for neurocognitive dysfunction to begin with. And what they found was even with substantial interventions involving hemi-arch replacements or total arch replacements and prolonged clamp times and cooling, that their stroke risk was actually quite favorable, relatively speaking, at about slightly under 8%, with a high degree of respiratory failure and renal failure, and again, a very favorable mortality of slightly under 9%, which when you consider the magnitude of these procedures and the emergent nature of most of them is actually pretty impressive. But what they did demonstrate was a similar predictable time dosing response curve, and that is the probability of having a stroke was directly related to the duration of retrograde cerebral perfusion time, meaning less than 30 minutes, the risk of having an identifiable stroke was about 5%, between 30 and 60 minutes at 6.3%, and beyond 60 minutes around 11%. Again, illustrating that you still need to get the work done and complete what you're aimed out to be, but knowing this can help you table or basically plan your operative approach to keep this in mind. And also recognizing that the outcomes in this population, you want to avoid sometimes doing too much surgery, and recognizing that we're dealing with a sick population to begin with. And so when you start putting this together, you need to recognize that there's a variety of advantages and disadvantages for the different types of not only antegrade and retrograde cerebral perfusion, but also when you apply that with different degrees of hypothermia. And illustrating the importance of communicating these things in advance so that you can develop a strategy, modify your strategy if necessary, and evolve from there. Intraoperative monitoring, I want to touch on briefly because it does provide us a real-time opportunity for then being able to do something about neurocognitive dysfunction once identified. There are a variety of options that are out there. I don't want to spend too much time in the interest of the fact that we only have limited time in emphasizing each one, but there's EEGs, jugular venous bulb saturation, near-infrared spectroscopy, process electroencephalograms, transcranial Dopplers, and more often than not, it's often a combination of two. So the point being is that there are different ways of managing and monitoring blood flow to the brain. Without going over all of this, because it's quite extensive, they all have their technical advantages as well as disadvantages for functionally assessing the brain during cardiopulmonary bypass and some of the tools that I mentioned before. And with some degree of overlap, which is why patients or why teams often will employ more than one technique. When you start looking at it, the real question is there a benefit? This was a paper that came out of the University of Colorado about a year ago, looking at slightly over 220 patients that had very complex aortic arch surgery. And what they did with some degree of neuromonitoring, they did recognize that when there were alarms, and they really weren't specific as to what the alarms were per se, but when they identified some degree of cerebral malperfusion or electrical problems within the brain, that there was a very high sensitivity and specificity, a very high negative predictive value, a low positive predictive value, and did allow for immediate intraoperative evaluation of the problem and alternative perfusion techniques to try to preserve the brain. And whether it's surgical correction of malperfusion syndromes or immediate postoperative imaging for potential opportunities for fixing what could have been an embolic complication, lumbar draining. The point being is that by monitoring it, you were able to dynamically alter your approach and surgical plan to improve optimization of the brain. This was another study that came around about similar time, looking at, again, intraoperative monitoring during aortic arch surgery, where, again, they looked at over 560 patients. And what they found was that there was at least some degree of changes in about 20% of the patients. Those patients that did have intraoperative changes were at much higher risk for having postoperative neurocognitive dysfunction, including stroke, and especially within the first 48 hours. So they were able to then come up with some degree of an algorithm that allowed for the team to intervene during the procedure if there was a change in the results of neurocognitive or neuromonitoring, such as looking at perfusion techniques, such as improving the brain perfusion, changing your cooling or warming approach, increasing the pulsatility, avoiding hypotension, particularly after cross clamp, and then also, if there is concern, immediate imaging with consideration for other therapies to try to improve brain flow. So as we start putting this together a little bit in practice, I want to emphasize that deep hypothermia is safe and effective. It allows for good exposure with a bloodless field that may facilitate the surgical plan. Patient management is critical when you start looking at overall bypass times, especially during rewarming. Keeping in mind that temperature management, gas management, hematocrit, steroids are all also tools that can be used to improve outcomes in this group. Communication with the team is also critical. Mild and moderate hypothermia may allow for shorter duration of surgery, fewer complications, and can be used even with complex arch surgery. But you need to consider other alternatives, because the last thing you want is to have a long period of circulatory arrest or brain ischemia and not being cold. Of the perfusion technology therapies that are out there, both antegrade and retrograde perfusion, as well as selective perfusion, need to be kept in your armamentarium, and they can be used for assisting in longer, more complex operations, particularly with moderate or more degrees of hypothermia, and that allows for very technically challenging interventions on the aorta as well as the arch. And neuromonitoring is also critical because it does allow for interventions. So when we sort of put this into practice a little bit, and this could be open for discussion or debate, if your cerebral arrest time is going to be less than 5 minutes, just taking a look at a repair, for example, or facilitating repair, you can usually do that with mild hypothermia or just drifting down. However, for periods less than 50 minutes, you can use either deep hypothermia or moderate, making sure that everybody is aware of what the plan is for both cooling and rewarming. But for longer periods of arrest time, particularly with complex interventions, you really probably should consider alternative cerebral perfusion techniques, either antegrade or retrograde. The advantages of retrograde is that you're able to maintain blood flow. In theory, you can flush out some of the embolic debris, including air, minimizing brain edema and neurocognitive dysfunction, particularly with deep hypothermia. Partial antegrade perfusion, either going up the innominate artery directly or the axillary artery, is simple and allows for continuous flow. However, you have to keep in mind that some of these approaches, when used unilaterally, may lead to incomplete brain perfusion if there are incomplete collaterals or an occluded circle of Willis. So as a result, you really need to optimize all of your different cannulation approaches, either centrally or peripherally. You have to have a decision tree that you're needing to recognize may change over the conduct of an operation, and making sure that everybody is aware of the plan. And you also need to take into consideration some of the patient-specific variables, such as previous surgery, if they've had groin cannulation in the past, which may complicate it, if there's existing aortic pathology that may complicate direct cannulation, as well as separating dissections from aneurysms. So in conclusion, I like to say that for much of this, we need to avoid exercises in what I call technique over judgment. There are things that sound really amazing and cool on paper or in theory, but when you apply them, don't always work out as planned. In other words, 2 o'clock in the morning on a complex dissection is probably not the time to do something new. Neuroprotection is critical for any and all cardiac operations, and you have to be open to improvisation and game day changes, which means anticipating the unexpected. To a certain extent, particularly with older patients with complex pathology, it's okay to leave things unfixed for a later time, or in younger patients, recognizing that you can come back with alternative approaches down the road. Sometimes doing more complicated operations, especially when applied to perfusion techniques, can make the outcomes worse and harder to get it right the first time. This is particularly true as we're evolving with more complex head and neck arch therapies and stent grafts, and pushing the envelope in who we're managing. So good communication, again, is so important between the perfusion plan and anesthetic plan, surgical plan. I incorporate this always as part of my timeout at the beginning of the procedure, not only to make sure that the perfusion team knows what we're planning on doing, but the rest of the operating and anesthesia team knows, especially if we're considering some degree of circulatory arrest and recognizing the professionalism of it all. And that is, ultimately, we need to recognize that we need to keep it simple. And at the end, we need to have an alive patient who is able to perform the activities neurocognitively that they came in for, and that they need to be able to go home to their families. So you really have to understand the limitations, not only of yourself, but of the team that you're dealing with. And with that, I want to thank everybody for showing up today. Hopefully we can do some of these things in person in the future, even though it seems like all of us have colds or even maybe a low-grade flu, hopefully not COVID. But I want to thank our sponsors, Specialty Care, and everybody, and hopefully we have a little bit of time for discussion. So I want to turn that back over to our colleagues and take it from there.
Wonderful. Thank you so much, Dr. Firstenberg. Clearly a tremendous amount of information to share in a short time period. So I thank you for this great summary. We have time for several questions, and I see there's a number of them in the Q&A section. So I'm going to start with Craig. Craig, if you don't mind, if you'd like to start with the Q&A that people have typed online. Several of them are all of them look very worth addressing.
Absolutely. Can you hear me, Al?
Sure can.
Okay. I wanted to thank Dr. Firstenberg, and I had a quick question before we got onto these. I was going to ask him, what is his go-to? We all get the 2 o'clock call in the morning, and it's from an outside source. What's his cannulation method when he doesn't know quite what's going on and needs a peek? And what is his neurological essentially best cannulation method at that point. If that makes sense, Dr. Firstenberg.
I'm not quite sure I understand the question, but one of the things I've learned over the time is, it's one thing if you're at a major medical center and you do hundreds, if not thousands, of these types of cases every year, and you're working with the same surgeons, the same perfusionists, the same anesthesiologists across the board, and you can really hone all these techniques. Some of this stuff is very complicated in terms of, and especially if you're not doing it routinely. And that's why more and more I just try to emphasize keeping things relatively simple. If I really try to avoid circulatory arrest unless absolutely necessary these days. Now, I may do a brief period of a couple of minutes here and there to facilitate taking a look, or to maybe put in a couple of repair stitches in an area that's difficult to deal with. But the point being is that, do you really need to replace that arch? Do you really need to replace those head and neck vessels in an 80-year-old that's coming in with, let's say, an aortic dissection or an aneurysm? And I think that's why keeping it simple is really something I try to focus in on.
Okay, we'll move on here. And we have a lot of awesome presentations, and thank you. Moderate
If you don't mind,
hyperthermia.
Greg, I apologize for interrupting. Michael, if you don't mind, we have a number, so if you can keep your answers as brief as you possibly can by
Sure.
I
Yep.
appreciate it. Sorry to interrupt, Greg.
We have one from Dominic Corella. Any role for medications like dexamethasone playing a neuroprotective role by inhibiting inflammation, apoptosis, and microglia activation? Do you have any input on that, Dr. Firstenberg?
The short answer is yes. And there's a variety of literature out there that all the bad things that happen in cardiac surgery, including neurocognitive stuff, and probably should have emphasized that a little bit more, can be minimized or attenuated a little bit with using Precedex. I try to advocate that in, starting it in all of my patients at the time of, surgery, because it has been shown to minimize some of the neurocognitive dysfunction. And also facilitating the postoperative management. Getting people to do that is a little bit hit and miss, particularly when you have to keep in mind some of the complications that are associated with it. But I love Precedex in everybody and anybody.
Another question from David Watson. I know when I was at my last university job, we would cool hard and fast. David's question is there any concern for cooling too fast with you as a surgeon?
The short answer is I have not seen a lot of data that suggests cooling very quickly as a downside to it, particularly in the setting that there's usually a reason why you need to cool very quickly. Meaning that, if you have, let's say, an aortic dissection and you are already having some degree of a malperfusion syndrome, you really need to metabolically get to a good spot as quick as possible and perfuse everything as quick as possible. So I think the benefits of achieving that are offset by any potential risk by cooling too quickly. And I think that there's probably some anecdotal evidence to suggest that maybe even cooling quicker avoids some of the temperature variabilities that may be seen in different body parts.
Excellent. Another question here. Mr. Rick Smith asks, do you modify the perfusate? Do you have your perfusionists when they're doing cerebral, whether it's antegrade or cerebral, do you have them modify the perfusate temperature while you're on circ arrest? Or what temperature is your preference?
I usually try to keep it whatever temperature we sort of right before we circ arrest at, so that everything is kept more or less the same temperature.
if you're going to 18, keep it at 18. If you're going to
Yes.
20, keep it at 18.
Yeah.
Right. Excellent. And we'll keep cruising down here.
As looking down, there's a question from Tim Fortier. Do you pack the head in ice, Michael?
Yes. Yeah, I think that that helps with a couple of things. One is, I think we lose track of the fact that the ambient air and room lights and all that can affect variability and particularly surface cooling of the brain. And so we do pack in ice, and we do give steroids as much as we can, even though we have to recognize that sometimes getting ice at 2 o'clock in the morning is not always easy.
Another question from Kartai, really concerning alpha and pH stat. Do you change from one technique to another when you rewarm? Say using pH stat to cool to get better global cerebral cooling. Do you then shift to alpha when you rewarm?
Is that Kira that's asking that?
Yes.
Yeah, exactly. My question goes back to him and asks them the same question, because to be blunt, I think a lot of this stuff is, at least in my mind, is very complicated. And the more complicated you make these things, I think the harder it is. So that's probably that's really the honors graduate class. I think there's a lot of talk about that, but I don't see a lot of practical aspects of it. And I think that I can't even give you a real honest answer. So I'll have to punt on that and send it back to him. He's just trying to stump me. And he succeeded. There you go.
Say, it sounds like he was successful.
Yeah, Al, I should throw that question to you. You're the senior perfusionist here. You should be able to answer that.
Yeah, I'm the old perfusionist, and I think that Michael did a good job. I think individuals did do that regimen. Start with pH, and then as soon as you start rewarming, perhaps over a certain target temperature, most of us will warm the temperature up, staying about 5 degrees below what the target temperature, core temperature was, and then shift to alpha. So now, again, the science with that, I don't know. There have been a few studies over the years, and most of these are very old. But I think that's more kind of opinion than it is good science. But with that, Michael, I'm going to thank you very much. We're running out of time right now. Great questions, great answers. It's a very difficult subject to address. And from a surgical perspective, a perfusion perspective, an anesthetist perspective, these are very, very difficult cases, and they're not getting any easier. So I thank you for the great summary. I thank Craig for doing a great job in moderating. And I want to thank everybody for participating in this evening's session. I mean, we could clearly go ahead and put another webinar of this magnitude in the future and not be redundant at all. Next month is going to be our last webinar for the year. And yours truly is going to present that on some work we've done on stress and stress management, and specifically how perfusionists are affected by this. So if you're able on the 16th of November to attend, we'd love to have you. As I mentioned, here's Dr. Firstenberg's email. He's a wonderful guy. Dr. Firstenberg and I have done a bit of research together the last several years. Wonderful person to work with, very, very extremely intelligent and very responsive. So to questions. So I'm sure he would not mind answering. Craig is here, myself are here. If you have any issues with any of the logistics, you're not getting your CEU or whatever, we're going to post this on YouTube. That'll be done within a week's time. And some of the questions that Michael was not able to address because of time, I think if you go back and look at the YouTube video, they were nicely summarized there as well. So with that, I thank Michael, Dr. Firstenberg. I thank Dr. Firstenberg. I thank Craig for this great job co-moderating, and Maggie Ring for the logistical setup of this presentation. And I don't know if there's any closing comments either of you have.
No, I appreciate
Sorry, go ahead, Craig.
Thank you very much, Dr. Firstenberg. That was a great presentation. And like Al said, it could have gone on for hours. It's such a great topic, and it's an ever-eluding topic right now.
No, and again, thank you very much, everybody. I think one of the challenges is that it is in constant evolution, and as our understanding the problems become more clear, it does allow us to ask more questions. And it's just kind of a never-ending battle, because some of these things, as you can imagine, are very difficult to study. And but I think we're getting better at it, and we're getting smarter. And I think this is really a very exciting opportunity to look at all this stuff more and more. So thank you very much, everybody.
Great summary. Thanks, everybody. Have a wonderful evening.
Thanks, Al. Thank you, Dr. Firstenberg.
Thank you, everybody. Appreciate it.